Here we have a case of fibrosing lung disease. The dominating feature is honeycombing. So we have the differential diagnosis of honeycombing, which is typical UIP or alternative diagnosis that can present with honeycombing. The honeycombing is peripheral, confined to the periphery, increasing an epicobasal gradient into bases. Let's see if we have non-UIP features. A non-UIP features for alternative diagnosis are nodules, ground glass outside the fibrosis, or consolidation. Here, we don't have nodules. We don't have ground glass in the non-fibrotic regions. The fibrosis is confined to the areas of fibrosis and no consolidation. We have here in the lower lobes lobular mosaic attenuation. Maybe this is exaggerated because of the poor inspiration of the patient, because we have here flattened posterior tracheal wall. So mosaic attenuation can be extenuated in such a case, but we can be sure that we have lobular air trapping here. In this case, and this is a feature of HP, we have to check whether this mosaic attenuation and air trapping are confined to the lower lobes, which is allowed in typical UIP, or included within the upper lobes. As we see here, the mosaic attenuation is confined to the lower lobes. So we are still in typical UIP pattern with no differential diagnosis. Otherwise, this will spoil the diagnosis. Typical UIP, according to the literature and the new classification for typical, probable, indeterminate for UIP, or alternative diagnosis, which is established in 2018. Typical UIP is not for surgical biopsy, and typical UIP pattern in HRCT is enough for the diagnosis with no differential diagnosis. And if differential is added by radiologist, that means that he wastes the value of his report, and the pulmonologist will not be happy for that, and he will take second opinion. So please bear in mind that typical UIP has no differential diagnosis if you are confident to the findings, and no features of alternative diagnosis, as we discussed it now together. And let's see, last thing that I want to emphasize regarding the bronchocentricity of fibrosis. Here you can see that the bronchovascular bundles are not included in the fibrotic process, which means no bronchocentricity for the fibrotic process of this patient. This can be seen along the pulmonary veins, it's allowed, but not along the bronchovascular bundles. No bronchocentric fibrosis. We saw here the right side. Let us here again, this is for the right upper lobe still. For the lower lobes, you see the bronchus are tapering, no bronchocentricity. Let's check for the left side as well to confirm the idea. No bronchocentric fibrosis, no traction bronchiectasis. So the fibrosis is confined to the periphery, which is the criteria of typical UIP. Last thing, you have to check for the pulmonary artery dilatation as a known complication for fibrosing lung disease. You measure the main pulmonary artery at the level of the bifurcation from wall to wall. If it is larger than 29 millimeter, so this is pulmonary hypertension. If not, so patient not yet developed this complication. Thanks for your attention.